Afternoon, everyone. Happy lunchtime and welcome to today's webinar. My name is Richard Torn. I'm part of Kaleidoscope Health and Care, and you've joined us for a discussion all about rethinking medicine. You might be sitting there going, I'm not really sure what that is. If you are sitting there going, I know exactly what it is, then if you can let us know, that'd probably be quite helpful. We're still working it out. Thank you so much for joining us today. Whether you're joining live or watching back, it's great to have you with us. This is actually the largest Rethinking Medicine gathering, albeit virtual, which has actually ever happened. So we're really excited about that. We hope you are too. We hope over the next hour or so, you'll get a chance to hear a bit from us about what on earth this thing is, but we'd love to hear from you as well about what it means to you and what's going on in your context. More about how you can do that in just a second. But we are joined today by a fantastic panel. And thank you so much for joining us. Jocelyn, do you want to introduce?
Hello, I'm Jocelyn Cornwell, and I'm the Chief Executive of the Point of Care Foundation, which is a charity that does work around support for staff and improving patients' experience.
Oh, thank you. Hello, my name's Alf Collins, and I'm Clinical Director for Personalised Care, for which read Person-Centred Care for NHS England and NHS Improvement. It's a privilege to be here, even though we are actually in a building site.
Yes, hi to everybody. Thanks very much for joining us. I'm Martin Marshall. I'm a GP in East London. I'm an academic at UCL and Vice Chair of the Royal College of General Practitioners.
Thank you all. It's a bit like a competition for who has the most interesting job. Would you like to be the Chief Executive of a charity?
Or the most titles.
Or the most titles, yes.
Yeah.
We'll get on to sort of letters after our names later. Not that is core to Rethinking Medicine. But thank you all so much for joining, and thank you for everyone who's dialed in. For everyone who is joining us live, we'd love to know a bit about who we've got on the call. So we're going to have a very quick poll, if that's okay. Well, what we'd like you to do is just think about how you would describe your main area of expertise. Let's launch that now. And so, how do you describe that? Sort of, what are you thinking? Are you coming from a clinical background, sort of management policy background, lived experience and/or patient voice, academia, or have our four options not covered your expertise? If you want to very quickly do that, I will just run through how you can get involved today. So 3 ways we would love to hear from you. So first, you can use the Ask a Question feature on GoToWebinar. It should have a little question mark handily next to it, so you can tap in your questions, comments there. If that fails, you're very welcome to email us, hello@kaleidoscope.healthcare. That's hello@kaleidoscope.healthcare. Or we'd love for you to be tweeting along. The hashtag is Rethinking Medicine. The hashtag is Rethinking Medicine, which if you put that in, will leave you about 14 characters to write the rest of your tweet. So we'd welcome sort of questions, comments as we go through, but also we would really welcome just hearing a bit more from you about why you've joined today. And particularly if you're sitting there watching this with colleagues, you understand some places are sort of live streaming this to meeting rooms up and down the country. If so, very warm welcome to you in particular. Please do let us know who is there with you. Thank you for all those who have just put in their poll responses. That is great. We're going to close that poll now, and we're going to share those results. So who have we got with us? Well, look, this is not a competition, but if it was, clinical colleagues, you have won. Congratulations. Well, what's lovely there? What a nice mix of people. 38% clinical backgrounds, 29% management policy, almost 20% lived experience, patient voice. Particularly warm welcome to you. Academics, always welcome. And sort of an other column. Again, if you put yourself as other, why don't you just send us a little message, just saying what box you would put your experience in, just so we've got a record of that. Thank you all very much indeed. Before we go on to hear a bit more about what on earth this rethinking thing is, Martin, I think you're going to kick us off. The eagle-eyed of you might have noticed this little jar here, which has got some money in it. This is the Kaleidoscope webinar swear jar. where we don't condone bad language at the start, just so everyone knows. But also any unexplained jargon, acronyms, we'll let you have NHS. Okay, you're not going to need to explain that, but others we might ask you to. We are going to ask for contributions for the Kaleidoscope Square Jar. All funds go to Thames Reach, the excellent homeless charity. If you haven't heard of it, do have a look at it. But we are going to be keeping an eagle eye, so I hope you brought your wallets. Martin, I'm particularly looking at you. But we'll be running that as we go through. So thanks again for joining. Do keep questions and comments going as you go through. But Martin, I think you're going to just tell us what this thing is and how you came to be part of it.
Yeah, I'm going to have a go. Thanks very much, Rich. So I've long been aware that my potential to help my patients as a GP working in East London is dependent on an awful lot more than my understanding of pathology and my understanding of therapeutics, and that awareness, I guess, has been brought to sharp relief by a number of the patients that I look after. And I want to describe just one of those patients to illustrate where rethinking medicine is coming from. So this is a patient who I'm going to call Mohammed. I've been looking after him for about 6 years now. He's in his late 30s. He's married with 2 children. He's from Iran originally, but he's been in the UK for about 15 years, something like that. He's overweight, and you probably won't be surprised to hear that he's got type 2 diabetes. So for the first year that I looked after him, I did everything that I'm trained to do to try to manage his diabetes, which I have to say has been a really major challenge. His diabetes remained poorly controlled. So I adapted his medication. I changed the dose of his medication. I added a new medication. I referred him to the specialist clinic in the hospital, and we added in insulin. For about a year, I was essentially adjusting his medication, and it had almost no impact whatsoever on his diabetic control. So called me a bit slow on the uptake, but after I decided I need to adopt a different approach. So I sat down with Mohammed. I asked him to make a long appointment, and I had a conversation with him to find out more about his background. And the story was fascinating. So Mohammed lived in an apartment, a 2-bed apartment with 4 beds and 17 other people. So they hot-bedded. They didn't have a kitchen, so he couldn't cook his own food. And he used to eat all his meals down at the local fried chicken shop, of which there are many in East London. And he loved it. He loved the food. He loved the volume of the food. He loved the cheapness of the food. For less than £5 a day, he could have 2 substantial meals. So he was extremely content in so many ways. And when I heard this story about the nature of the environment that he was living in, I realized that I needed to change tack, that in what I thought was a problem of under-medicalizing, i.e. I was trying to give more drugs or different drugs, was actually an example of over-medicalizing. So I tried a number of different things, and I've been very fortunate in my practice in East London that we have a number of different kind of approaches to providing care that move beyond conventional medicine. So the first thing I did was referred him to a law clinic that we had working within our practice. And remarkably, within 6 months, we'd managed to get him rehoused, which is fundamentally important. I also referred him to a jobs club, and within 3 months, he'd got a part-time job. I then referred him to an exercise and prescription scheme, which our local government, the London Borough of Newham, had been running. And I then referred him and his wife to a cooking on prescription scheme, which had been run by a local third sector organisation. So basically, I completely changed the nature of what I was doing as a doctor. And I have to say my role as a doctor in this was actually quite important. So whilst you could say, well, anybody could make those referrals, or Mohammed ought to be making direct referrals rather than doing it through a GP, my relationship that I had with him, that I built up over time, a relationship of trust, allowed me to persuade him to try some of these rather different approaches to managing his diabetes. Now, I'm not going to pretend for a second that there was some kind of Damascene conversion, that Mohammed is now running ultra marathons and he's training to be a teacher. That's not the nature of life. But actually, he's in a much better place 5 or 6 years down the line than he was when I first met him. So he's losing weight. He is exercising more. He's got a great sense of pride that he's able to support his family. His diabetes is better controlled. He still eats occasional meals down at the fried chicken shop, but we can't win everything. So this experience as a clinician, I guess, has motivated me, and it motivates many other clinicians to think differently about our role as doctors, whilst we recognise the remarkable strengths of the medical model that we're taught at medical school and we use, and let's face it, it's so useful in so many different ways, it doesn't address so many of the complex problems that we address within the health sector, not just in general practice, but across all specialties and all areas of work. So what we're seeing as a consequence of that is doctors not just perhaps feeling slightly uneasy about the medical model, not just talking about doing things differently, but actively engaging in the kind of things that I prescribed. They're actively engaging with the concepts of social determinants of health and social interventions. They're actively engaging with concepts like overdiagnosis, over-medicalization agenda. They're actively engaging with the assets that exist within communities, as I've described, for example, with the cooking club. And they're actively engaging with things like systems thinking rather than just focusing on the narrow patient in front of them. So for a whole range of ways, doctors are starting to behave differently. And I think as a consequence of that, Alf and I and many others have started making connections with other people, not just doctors, but patient representatives, system managers, policy leaders who are interested in this territory. We've got together over the last year. We've been developing ways of describing what's important. We've been trying to present a kind of narrative. We're trying to present an action plan, which Alf will be telling you about. And I have to say, we've really tapped into an enormous amount of energy that's out there. So we've already got about 130 people who've actively signed up to contributing to the development of Rethinking Medicine. We've talked to similar initiatives in other countries like Prudent Healthcare in Wales and Realistic Medicine in Scotland. We're starting to develop, I think, a sense of energy and almost, dare I say, a social movement, although I'm slightly worried about using that term now because it's such early days. But there's something going on out there which I think is really exciting.
Martin, thank you very much. A lovely run through and a fantastic story as well.
And no penalties
I didn't spot any. If anyone's watching and think I've missed something,
I had my money ready just in case.
Do. If anyone can't quite see how much money Martin's got, I think you've got 40 pence. Congratulations. You've got a pound. Well done. Okay. Right. We're hoping that no one spends a penny in so many ways. Martin, thank you very much. Again, what we'd love to hear from you is sort of what really resonates. Sort of why have you decided to join this call? What is it about it which is drawing you to this? And the same question to you, Jocelyn, to you, Alf. Why are you here? What's drawn you to Rethinking Medicine? Jocelyn.
Okay, so I've had a lifelong fascination with medicine without being a doctor. And I'm a medical sociologist, and for decades have worked in and around the health service. In management and regulation and other places. And my starting point has always been a sort of natural, instinctive alignment with patients. Perhaps because there was mental illness in my family, who knows, but that was kind of my orientation. And I've been very aware throughout my career of the power differential between patients and the people who look after them. And if I tell you a story, I'll tell you a story about what's happened recently to the husband of a friend of mine, which I think explains why I think rethinking medicine is so important. So he's called Robert, and he's in his 60s. He has symptoms of prostate enlargement, so he's been peeing more frequently and getting up in the night. He went to see his GP, just said, we'll just watch it, we'll keep an eye on it. He went to see the GP because he was getting up more frequently and losing sleep, and was referred to an outpatient appointment, not told what specialty he would be seeing. Goes to an outpatient clinic, sees a junior doctor who says, I'm Matt, doesn't say anything else about what team he belongs to. Says, I think, you need an MRI, and I think we'll admit you tonight to see what's happening. And on the one hand, he was reassured that he was going to be investigated. On the other, he was a bit alarmed at the urgency of this. In the evening, he was visited by a consultant. Again, no name, no description of which specialty. Robert didn't know whether this was renal medicine or urology. Who was looking after him? The consultant said to him, I've come to tell you essentially that I've seen the results and you don't need to worry about cancer. The next day, but you will need to have a catheter fitted. The next day they had 3 goes at fitting the catheter. A nurse, then 2 different junior doctors. He passed out and he was discharged with no information about how to look after the catheter, no information about what the observations were and how they'd concluded, and the message that he needed to come back for a biopsy. So when I saw my friend, what she said was her husband was deeply depressed. He was stuck indoors. He was afraid to go out because he didn't know how to manage the catheter and actually felt it was humiliating having it, and had these mixed messages about no cancer, but you'll come back for a biopsy. And in a way, that story encapsulates so much of what I think is wrong with the system that we have, which is that what's the sense of who inside this is responsible for looking after this patient in the round as a human being and thinking of him as a person. And from the work that I do at the point of care, the other side of it is that I know that many clinicians who we work with feel, I don't know what word to use, but both resigned and somewhat depressed about the state of things and their inability to take action, really to look after patients in the way that they thought they would when they first got involved in medicine. And to me, this sense of powerlessness in the patient side and on the side of the professionals is a really big issue that I think needs us all to rethink both the way that doctors are trained, the way that they're supported, the way that they lead, the way that they perceive their role in relation to the patients. And as part of that, we certainly need to amplify the voice of the patient, but we can't do that unless we properly, it seems to me, and effectively, unless we also accept that doctors feel anxious about that and need support in order to really engage with patients. So that's why I'm involved.
Jocelyn, thank you very much indeed. If anyone was joining thinking that this wasn't a big agenda, which is going to take quite some time to make progress on, I think you're probably in little doubt now. Jocelyn, thank you very much indeed. Alf, why are you here?
Thank you. Yeah, they're powerful stories, aren't they? So I work in NHS England now full-time. I started life as in my profession as a consultant in pain management, working in the community, working with people primarily with back pain or total body pain. I was trained in England and in Australia and in the US, and I was trained to do things to people. I was trained to give injections and to dole out medications. So I started doing that as a full-time consultant because that was what I was trained to do. And of course, what you realize as a consultant is that you're with these people month in, month out, often year in, year out. And I realized a few months into my consultant career that people were coming back because the treatments that I was offering them, I was doing to them, weren't actually working very well. So I realized that there was an awful lot I was missing out on in terms of how I could relate to, how I could work with people with pain to support them to live well. So I went off and got trained in psychological approaches. I got trained in motivational interviewing, in health coaching, and I realized that there was a whole toolbox of ways of working that I was missing out on. And more importantly, the people I was working with, the people with back pain and total body pain, were missing out on as well. And I realized that I was working with them in an entirely pathologically driven way. What's going wrong? What can I do to help you fix it, or to fix it for you? Whereas if I started asking people different questions, tell me more about the way life is for you. Tell me about what you know. Tell me about what you want to know. Tell me about what you do. Tell me about what you'd like to do. I realized that these were whole ways of working that people had not experienced before coming to our team. And I realized these were ways of working that were about ordinary, everyday human conversations that somehow people were really missing out on. And so really since then, my whole career has been about how can we start to shift or to support the profession to shift along these ways of working. It's not a matter of saying goodbye to the pathological model, the what's wrong with you model. It really isn't that. It's a matter of complementing that with other ways of working. As I've moved into policy, I've been I've really experienced lots and lots of other professionals working in similar ways that haven't articulated it in quite the same way. So the multi-morbidity agenda, the social determinant, social prescribing agenda, the overdiagnosis and overtreatment agenda. I think we're all speaking to something underneath that which we share. And I guess that's what rethinking medicine is all about.
Thank you. Thank you very much indeed. And just to sort of follow on one of your points, that I think if anyone's in any doubt, this isn't about saying medicine's rubbish, and we should eschew antibiotics and anesthesia and try something different. This is slightly more nuanced than that.
Absolutely. This is augmenting the medical model, evolving the medical model into a not just what's the matter with you, to a what matters to you as well.
Okay.
As well.
It's upgrade, not substitute.
I see it about as being about balance.
Okay.
That the weight over the last decades has been so much towards the clinical and the technical for very good reasons that it's got unbalanced, and the humanistic side is getting thinner and needs to be strengthened to balance up.
Thank you very much indeed. So we are again would love your comments, reflections as we go through, particularly on this balance point, and we completely recognise that this is going to be different in different areas. So if you think it's particularly the case in your area or particularly not the case, again, we'd love to hear from you. Just to say before we go on, and we're going to hear a bit about sort of what's happening next with Rethinking in just a second, that you might be wondering why we've started today's webinars with a set of stories. And I think it really comes back to your point, Martin, that I think what's been fascinating about seeing Rethinking develop is how these stories resonate and how we've been met with similar stories back from a whole host of people we've spoken to and worked with. And we talk about social movements, and sort of the core of this to us as we see it is this power of stories. It's this power of personal experience, actually, of tapping into something slightly wider. We'd love to hear your stories as we go through. Well, before we, Alf, we'll come to you in just a second about what's going to happen next with Rethinking. But before we do, we would really like to hear sort of what aspect of Rethinking Medicine sort of most has drawn you to it today, that you can think of Rethinking a bit like Everest, in terms of it's got different faces, it's got different aspects to it, and it will look differently from whichever way you come at it. So we're just going to launch a quick poll now. What we'd love to get your very quick views on. So which aspect of Rethinking most draws you to it? Why you might be here today? Is it that sort of social determinants of health and inequality, very much playing to Martin's story? Is it about multi-morbidity? Is it about the rise of multiple conditions? Is it about overdiagnosis, overtreatment? You might be involved in something such as choosing wisely, for example, and wanted to find out more about Rethinking. Is it, coming back to Justin's story, about sort of patient-centered care, shared decision-making, or have we failed to capture within that what most draws you to it? We'll take responses just for a few more seconds. We're saying sort of it is picking your top one. More than one is allowed, not in our survey, you can only pick one. But we recognise that these are playing to different people in different ways. We will close the poll in 5 seconds, so if you haven't voted, please do so now. Thank you very much indeed, and we'll just share those results back. So it's the first time we've run this, so this is genuinely interesting for us to sort of pour over. Patient-centered care and shared decision making coming up as a leading factor. 2 or 5 of you, 4 and 10. Followed by social determinants, 25%, then overdiagnosis, multimorbidity, 8%, and other, another 8%. Again, if you put down other, please do send us a message about what in particular you are thinking about. Martin, first reactions on our scientific poll.
Really interesting, isn't it? Over the last year, we've had conversations about whether we keep rethinking broad or whether we focus down on one issue. And those more managerially orientated than I have say you'll only achieve something if you're really focused. I'm not sure that is the case, because I think all of these are important, all of them are legitimate. Yes. And I think as this poll demonstrates, people engage with them in different ways. So I think it's great that there are a number of different elements and most of them are engaging to people.
It's a diversity of thought. Who would have thought it? Lovely, thank you very much. We'll hide those results. Thank you. We'll share all of these results back with attendees at the end of today. So just a reminder before we come to you, Alf, this is a big trail now. This better be a good next section. But just to remind you how you can get in contact. You can use that Ask a Question feature on GoToWebinar. You can send us an email. hello@kaleidoscope.healthcare, or do feel free to use Twitter. Hashtag is Rethinking Medicine. If you're joining us after the event, that Ask a Question feature probably less useful, but we'd still love to hear your views by email or by Twitter. So we've heard about what this thing is, sort of where it comes from. What's going to happen? Where's all this going?
Thanks, Richard. I think the first thing to say, I think we've made really quite significant progress over the last year. Many of you will have seen the editorial in the British Medical Journal at Christmas, which there was an awful lot of engagement with that editorial.
I'm going to call you off on that, Alf. You've implied that people have read the BMJ, so I'm going to take some money. Thank you very much.
British Medical Journal. I'm so sorry.
When was this editorial out? Why would people have read it? Come
on.
So
sorry.
Thank you.
I feel the need to put 2 coins in there.
Well, no, I'm not trusting you. Not to hold it else.
You don't need that later.
Give us a bit more explanation.
So the British Medical Journal, kind of one of the most widely read journals by medics in the world, ran its Christmas edition. Its Christmas edition is very well read indeed. Just before Christmas, and we
Christmas edition just before Christmas. We'll make it
thank you very much. And Jocelyn and Martin and I, with the help of our Rethinking Medicine reference group, put an editorial together, and it came out on the British Medical Journal website, so is accessible via their website. Although I have to say, to our shame, it's not actually readily accessible to all members of the public, because you have to actually pay to get onto it. I wish I
about to be. I
now wish I didn't go down that track. And what we've also got is a reference group, a small reference group of nearly 200 people. We've got nearly 800 people engaged with our programme of work so far via Twitter. What we've developed now is a narrative, which is on our website. Can we let people know the website and how to engage with the website at the end of this?
We can let them know now as well.
Is that okay?
rethinkingmedicine.co.uk.
Brilliant. Thank you very much. So do look at it. There's a number of blogs on there, and there's also our narrative for why we think it's important. But do engage with it. Do, if you want, send us a blog. Please do that. What we're doing next is we're going to have a further meeting of our working group. What we want to do is condense that narrative into a set of core principles. That's what's happened in Wales, it's what's happened in Scotland, and they've really, in Wales and Scotland, been a kind of a jumping off point for people to start to develop a series of activities, or to make sense of a series of activities that are already happening, to see how they fit together. And the place we're moving to, and we're moving to it in a number of different ways. We've got a policy influencing piece that we're really working on. We've got a strategic working group that we're working on how we engage more explicitly with you. We've also got a group of people who are sitting there behind all this, program managing it. But what we really want to do is, through all this process, develop a set of really clear principles so that together, as long as those principles are shared, we can start to move to action. And it's a real kind of tension for us. It's just to, you know, when do we stop thinking and start doing? Is this all about thinking and doing at the same time? We do want to move to action, but we also want to make sure that we all move to action together.
Is there something also about the fact that when we first started to meet, it was very clear that a lot of people were already very active, doing things that were connected to rethinking medicine.
Exactly.
So in our case, I would highlight, say, the teaching and training that we do around experience-based co-design and teaching clinical teams to work differently with patients as equals and to work with patients in the change process, which is radical and which has and which really boosts the morale of the people who are involved enormously. So I see that as linked to rethinking medicine. I think that there are people in the groups that have formed around rethinking medicine who cite all kinds of work in general practice, in their communities, with the third sector that are relevant to this. And that's something I think that there's an ambition to kind of say that activity is linked to this thing, and we could boost it all if we had some way of making sense of all of this. And also do new things as well, but it's not all about new, is it?
Absolutely. Thank you, Jocelyn.
So I think that's a second of the common misconceptions I think we were keen to dispel. Firstly, this isn't about saying that that's the end of medicine. Neither is about saying that no one's had these ideas before.
No.
Moses, what is distinctive about this?
So I think, just building on Jocelyn's point, it's absolutely clear that there is a lot of activity out there, as we've all described. And the Rethinking Medicine label is being used as a kind of catalyst, maybe, or an enabler. We have called it a force multiplier.
Force multiplier.
Horrible term,
What's
technical
a force
term.
multiplier?
I have no idea what a force multiplier is, but it is essentially a catalyst. It's a way of bringing together these initiatives. And the very last thing that we want to do is to suppress or duplicate any of the good work that's going on out there. What we do see, however, is if you speak to a lot of frontline clinicians, they don't see a link between these activities. It just feels like lots of stuff, much of which is imposed from above. So what we're trying to do is to create a compelling narrative, which then allows them to see how it joins together and how fundamentally it's about how do you practice medicine and how are you effective as a clinician.
Yeah.
Can I just add, and I think there is that piece about how do they link together? How do we, encourage and support people to keep going along the kind of paths they're already taking, and what else do we need to do as well?
Yes. Yeah. Okay. Well, that's I think really important point to make. That I think if you're joining thinking, I just want a list of all the activities Rethinking Medicine's doing. Well, some of it might come from the reference group and others, but we'd also hope that some of it comes from stuff which we've never heard of before. And so what we'd really welcome is if you wanted to email us again, hello@kaleidoscope.healthcare, or get in touch through the rethinkingmedicine.co.uk website. We'd love to hear of activities which you're already involved in, or things which you've got planned, which you would see as sort of a slap bang on the Rethink Medicine territory. I think this is one of those occasions when we actively welcome all tanks on our lawn, tanks, any other sort of military vehicle you wish, or non-military vehicle you wish. It's a whole host of things going on, which would really would love to hear how it's playing with you and sort of what's going on in your particular area. Al, thank you very much indeed. So key to it developing is the work with the reference group. You've mentioned the website. I think people can sign up to be part of that reference group on the website if you're wanting to hear more about it. In terms of outputs of Rethinking Medicine, so if people are waiting for a big tome or a sort of update, sort of what's likely to come out of Rethinking Medicine? What sort of things might people be seeing?
So I think there's still more for us to do around engagement. We're thinking about whether a conference is the right thing to really focus on over the next few months. I think it's likely we'll move in that direction. I think that piece around distilling all these ways of thinking, these ways of working, not just into a narrative, but a set of core principles, which again is what they've done in Wales and Scotland, I think is important. But I think this is something that there is something here about an iterative process. We don't want the working group to do all the work, or indeed the reference group. This is about an iterative process where we want to engage with everyone to make sure that we are all moving in a similar direction.
Lovely, thank you very much. So this is, we've got about 20 minutes or so where we'd love to hear from you. And we've already got questions flooding in, so thank you very much indeed for those. As a reminder, your 3 ways to get involved are use that ask a question feature. You can tweet, Rethinking Medicine being the hashtag, or you can send us an email, hello@kaleidoscope.healthcare. Any of those are good. So a whole host of things coming in. Thank you very much indeed. Well, let's start with the first question. I think crucial one in terms of patient involvement within this. Alf, do you want to kick us off? What are the plans here?
Yeah, it's really important, isn't it? This really important. So we took a strategic decision in our working group perhaps a year ago that whilst we were working with advocates of the patient voice, Jocelyn, Angela Coulter, members of the team from National Voices, this is about the medical model. And what we wanted to do was start by working much more explicitly with medics, with doctors, actually. I think the time is ripe now for us to start to think again about when is it that we more explicitly work alongside and with patient groups, the public, and I think that's a conversation we should all be having. Others might have a different view. I don't know.
I think Jocelyn first, and then I'll follow you.
That's dangerous.
I didn't say I'd agree with you.
Okay. So my view, the reason there's lots of work going on, led by patients around the country, and I hope that Rethinking Medicine will be connected to that. My view is that there's that actually, as Alf says, this started as being about medicine itself, and I very much want to see doctors leading this attempt to rethink medicine. I think it's their call, really. And I think that the idea of patient involvement in the abstract, to me, is meaningless. It's more, what they are doing, that we collectively are trying to do, requires patients to be involved as patients, as opposed to just citizens or members of the public. And for that, when we're clear about the purpose, then I think we should also be clear about the processes we're going to build and how we're going to go about it. But it worries me that almost everything in the NHS these days starts with, well, what are we going to do to involve patients? And actually, that means jumping over the first thinking that needs to be done is, what are we ourselves trying to do now? And do we need to involve patients, and for what? Because patients have actually got lives that don't, they've got other lives to live than help people solve problems in the healthcare system.
I know that will come as a shock to many of my former colleagues in policy-making bodies up and down the land, but patients have lives. Remember that. Martin?
So I think the biggest fundamental cultural change, which is encompassed within Rethinking Medicine, I think is the relationship between clinicians on one side and patients on the other. And I don't want to sound like a sociologist, which I'm not, and Justin is, but it's about power, it's about the sharing of power, it's about the nature of knowledge, it's about challenging scientific knowledge as being a good but also not the only form of knowledge. It's about relationships. So I don't think you can have any of those conversations unless, in the first instance, doctors and patients are talking to each other. Now, the wider question then is, but what about other health professionals, particularly in an environment in which we're in a very exciting way? We talk about a much more multi-professional approach towards delivery of care. That's really important, but we've got to start somewhere, and doctors seems a really good place to start.
Lovely. Good. You may agree, you may disagree. We'd love to hear from you either way. We're going to move on. I think we've got a whole selection of questions, which I'm going to throw to our panel. So one about evidence-based. Thank you very much for this one. So how do we build the evidence base to make the business case for developments which don't easily lend themselves to transactional assessment. I think that's probably core to so much of rethinking. I'm going to give that one to Martin. Congratulations, Martin. I'd like to talk about evidence base in just a second. One about assets. We talked quite a lot about social determinants, assets-based community development. I'm going to put some money in there. There we go. Lovely. Good question saying, what do we mean when we say assets? Do we mean community assets, or it comes to assets and strengths of patients themselves? Jocelyn? Would you like to pick up that one? And hold on one second.
Sorry.
And then just a wider question about actually how does this thing fit in with wider policy priorities? For example, personal responsibility for patients in primary care. So, Alf, not to put you on the spot in any way as the clinical lead for a large policy-making body, but a general point about how rethinking fits with wider policy priorities would be fascinating. So we'll start with Martin on evidence-based, Jocelyn on assets and strengths of patients, and then Alf will work out a politically correct way of talking about policy. Martin.
So let me kick off from academic head on. I'm an advocate of evidence-based medicine. Using appropriate evidence to inform decisions that we make is really important. And the very last thing I want to do is for rethinking medicine to shift us from a field in which we have been building an effective evidence base for all the deficiencies, but we have been effective building one to a place where there's no evidence or little evidence guiding what we do. Now that isn't actually the case, because if you look at the evidence underpinning things like shared decision making, things like addressing social determinants of health, things like social prescribing, the evidence base is of a different nature. And certainly weaker than the clinical evidence base, because there hasn't been much investment in developing it, but it is there. So my view is we need to continue asking questions about evidence. We need to use a range of different methodologies, some of which are standard ones that biomedics will understand, and some of which are not. So we need to continue building the evidence base, but we shouldn't use calls for evidence as putting a brake on this as a movement. There are times when you can use a bit of common sense and a bit of theory to drive change in a particular direction, as long as you're committed to evaluating it along the way.
Lovely. And if there's anyone sitting out there going, I'd love to reevaluate rethinking medicine, and I'll do it free of charge, then probably we'd love to hear from you. Jocelyn, about assets, I'm going to throw in another question, which is through as well, if that's okay. Someone's saying, is there something we can do together to understand better what people actually want when they see a doctor? Is there a way to turn this shared sense of frustration into activation, and can patients actually be supported to drive this change? And Alf, I know you want to say something about that as well. Yeah. Jocelyn.
So the question about assets, what do you mean when you say assets? Do you mean community assets or the assets and strengths of patients? I think I could speak for everybody, we think of patients as assets, having assets themselves, and that actually without them, we're kind of doing the work of change with one hand tied behind our backs. So I think patients have full lives, and many of the patients who I've worked with over the years have taught the teams that they work with all kinds of skills and knowledge based on their lives as lay people with careers and all the rest of it. So I think we really need to remember that. What was the other one?
So in terms of, is there something we can do to better understand what people actually want? And see a doctor, that sense of frustration, turning that into something more positive.
What do they want when they see a doctor? I mean, we have a lot of evidence now on what matters to patients about their encounters with doctors and healthcare professionals, which is always the relational aspects of care that trump everything else. So they want to feel trust. This is not just in doctors, it's in the team, or the teams, plural, looking after them. They want to feel that there is good teamwork, that the people who are looking after them work well together and communicate well with one another, and they want to feel respected as a person. They don't want to have their dignity and their sense of self undermined by their encounter with professional services. They want it to be protected and, if anything, enhanced. So I mean, that there's lots of evidence. Some of it's qualitative, much of it's based on good quantitative analyses of masses and masses of patient surveys.
Jocelyn, thank you. Alf, we're going to come to you on policy alignment, but Martin, I'm just going to tee you up for a nice easy one. Thank you very much indeed to whoever sent us this question, which is, bearing in mind that there are drivers in the system which create the problems you outline, how realistic do you think rethinking medicine is? Thank you very much. I'm particularly pleased for that one. That's a lovely question. Alf, alignment with wider policy, and then Martin.
So many of you will have seen the BBC today, when there's been quite a lot of reporting around the fact that NHS England are going to be supporting link workers, people who sit in the centre of social prescribing schemes. We're going to be supporting about 1,000 link workers in primary care over the next year, going up to 4,000 or 5,000 over the next 3 or 4 years. And that's all part of what we're calling the comprehensive model of personalised care, which is launching towards the end of the week, which actually is really about the what matters to you conversation. It's about having a conversation with people, supporting them at the beginning of the conversation we have together to say, well, tell me what you want to get out of the time we spend together today. You know, what's important to you? And then having a negotiation between the person, the patient, and the professional about the medical aspects as well. But it's what matters to you first, the clinical aspects second, and together that shared agenda. And that's really what the comprehensive model is all about, although we've written it out over nearly 60 pages. So look out for it when it comes out on Friday.
And then just remember, it can be described in about 20 seconds. I'll think about, I think an important point that this is, I think there's alignment with bits of government policy, but this is, I think, in a different way to prudent healthcare and realistic medicine in prudent healthcare in Wales, rethinking realistic medicine in Scotland. This is not a formal government programme. This is something slightly different.
Yeah, I think it's really important to recognise that both prudent and realistic have come from the centre. Whilst I'm here as a representative of the centre, this is about shared ownership. I think we all really strongly believe in that.
Martin, is this in any way realistic?
Yes is the answer, and before anyone accuses me of being Pollyanna, let me explain why. Partly because I think the stars are aligning. So we've described already that clinicians are saying there's something about the way that I've traditionally practiced medicine that doesn't seem to be working, that is unsatisfactory, and therefore they're engaging with other things. But actually, patients are also saying exactly the same thing. We want to see medicine practiced in a different way, and we want to see medicine in a way that values not just hard scientific evidence, but my preferences as well. But, and the big but, in addition, we're seeing policymakers starting to engage with this stuff. And the reasons for that, I think, is we have, as a medical profession, working through policymakers, we've almost overpromised what modern medicine on its own in a traditional way can deliver. And policymakers are recognising that there might be higher value ways of investing the resources, limited resources that people have, in producing better change. So policymakers are there or thereabouts. And if I give you just very quickly a practical example from my background in general practice, in 2004 we had a new contract with the Quality and Outcomes Framework, which was a way of incentivizing particular clinical behaviors. It's had a massive impact on the way that doctors, what doctors do and how practices are organized. It's had almost no impact on outcomes, interestingly, surprisingly, mostly because the social determinants of outcomes are far greater than the medical determinants. But what it did do most clearly is focus doctors' attention on the medical things and much less on the interpersonal and relational aspects of care. Now, what we're seeing is progressively policymakers understanding that, and there's been a review of the Quality and Outcomes Framework. And it's possible, we don't know yet, probably sometime this week, hopefully a new contract will be announced. It's likely, I think, that that new contract will look different, that it will put a stronger emphasis on managing the more complex aspects of care, which is what Rethinking Medicine is all about.
Yeah, Martin, thank you very much, Steve. We've got about 10 minutes left, so if you've got some burning questions, please do send those through. We're going to come on in just a second in our remaining time to think about what's going to be coming next. I know there are questions about timeline, but a lovely question, which Jocelyn, I wonder if you want to start, and then Alf as well to get your view, which is, thank you very much, somebody's running, saying if you had started this conversation 10 years ago, what would be different now?
10 years ago, 2009.
Good.
I probably would have been banging on about exactly what I'm talking about today. Sorry about that. But I feel that things have changed. I think I like the expression you use, Martin, about the stars aligning. I think that over the last 10 years, or I'd say 20, the urgency, if you like, of the personalization agenda has become very apparent. But I guess what's become even more apparent more recently is the disaffection of people within medicine, the medical students who are leaving without qualifying, the young doctors who are leaving very rapidly for other careers, the concern about doctors taking early retirement, and underneath all of that, I think, is a disenchantment, a loss of almost faith, of a vision of medicine which can be practiced really in a satisfying way. And I think that's become much more apparent over the last 10 years. And I want that to be part of this agenda about rethinking medicine. I think kindling excitement and love of medicine and of what it can do for patients and for society is just a really important thing for all of us. And so I want that very much to be part of this. I don't want it to be all about policy and frameworks and action plans. I think there's something very deep about this which is important.
Awesome, thank you very much. Alf, what would be different now? And then Martin, I'm going to ask you about whether this is just about GPs. Alf.
So yeah, I really like that phrase, love of medicine. Yeah, there's something about that in the heart of this for me. Two pieces that I think have really shifted over the last 10 years. One is our thinking has progressed across multiple fronts. The overdiagnosis and overtreatment agenda was quite fresh then, and there's been an awful lot of thinking there. The multimorbidity agenda wasn't so apparent. Person-centered care, personalized care, we got lots of ideas, but we haven't brought them all together as a kind of a comprehensive way of thinking. So I don't think we were in a great starting place 10 years ago. And I think now is the time for us to bring them together. And I'm particularly grateful for choosing wisely for the prudent healthcare and the realistic healthcare leaders, because they've shown us how all this stuff can start to come together.
So no, it's not just about general practice, and I think a number of different medical specialties have been involved in the discussions we've been having over the last year. I think it's probably fair to say that there are certain branches of medicine that are more inevitably aligned to this kind of work, who build their existence around, I haven't got any money, a biopsychosocial model. Thank you very much. A biopsychosocial model, a model that moves us beyond the traditional model of medicine. And general practice is one of those, but pediatrics is another, mental health very clearly, psychiatry is another, and care of the elderly, geriatrics is another. So there's certain specialties. But when I talk to some of the more technical and craft-based specialties, orthopedic surgeons, for example, some of them are very engaged with some of this stuff. Conversations with patients using patient outcome measures, like functional measures, to decide whether a hip or a knee replacement is necessary. That is absolutely core to their existence and their effectiveness as a doctor. So it's relevant to all branches of medicine.
Even if you're an orthopedic surgeon, there is hope for you yet. Is that
not so?
Martin, thank you very much. We're fast running out of time. So I'm going to come to our panel in just a second and just ask, so we're sitting here on a pretty chilly day in January. By the time it gets a bit warmer, let's say by June, July, we hope, what will have happened by then? What practically people will be able to see? So in just one moment, we'll start with Martin, then Alf, then Jocelyn. But sort of whilst I'm giving my esteemed colleagues time to cogitate that, thank you again for people for joining today. As I said, this has been the largest rethinking gathering to date. And we would love your reflections on what, from the past 50 minutes or so, has really hit home for you. So if you want just to get in touch, again, either by Twitter, that hashtag Rethinking Medicine, or if you wanted to send us an email, hello@kaleidoscope.healthcare. And we'd just love just any sort of closing thoughts from you about what you've taken from this, and what you might want to do with it, how you might talk to colleagues about it following today. Please do just get in touch. We'd really like to hear from you. So we'll go to Martin.
So in 6 months' time, more people will be talking about this stuff.
Okay.
So I don't think we need any hard outcome measure to drive this. I don't believe that this is an agenda that can be managed. I believe change happens through conversations, sometimes difficult conversations. I'm always amazed at how when many parts of the NHS feels like they're close to an extremis, massive stress, that seems to be the time when many clinicians want to have these kind of bigger conversations, and my sense is that people are doing that. So more people will be talking about it, more people will be engaging with the specific activities that we've been talking about, more people will be going to conferences and listening to presentations, more people will be engaging through social media.
Lovely. Oh.
I'd agree with that and say and for me there is something about us together developing a little bit more clarity about what those kind of categories of work that are already happening are, and how those categories of work fit together and kind of distill into a set of principles. That's my thinking.
I agree with Alf. I think that we've talked about a lot of different things today. I'm very aware of that, and it's an enormous agenda. So I think that putting better shape on it than we've done so far, and then in some way chunking it up so that you can feel engaged with a particular aspect of it, knowing that the other things are connected without feeling that you have to cover all the bases all of the time, I think would be a good place to be, so that we had some very clear delineated areas of work perhaps, or activity, and the principles, and that people could in some way engage more intensively with some than others. I think that would be a good place to get to.
Lovely. Jocelyn, Martin, thank you very much indeed. We're almost out of time. I think just to pick up your point, Jocelyn, that I had a conversation with a former colleague who was saying, as a policy organisation, we'd love to be able to send a response to Rethinking Medicine, which was a bit of a funny conversation, because I sort of said, well, we'd rather you didn't. Sort of, what you're not going to see over the coming months is something put out to consultation, where we're going to ask august bodies to send back responses, which we'll pretend to read. Instead, what we'd love for you to do is just to join this conversation, just to help us shape it. This is equally yours as it is ours. This is a movement. This is something which we hope resonates with you, and if it does, we'd love for you to be involved. So coming back to Martin's point earlier, if you'd like to write us a blog for the website, rethinkingmedicine.co.uk, please do. We'd love to hear your reflections on today. If you wanted to host a discussion in wherever you are, whether that's your organisation or system or ward, to talk about these concepts, we'd love it. We'd love to hear what happened as a result. So do treat this as yours. Do really get involved. If you could let us know, that would be nice. But this is far wider than sort of these four walls here. As closing thoughts, just to say thank you so much for everyone who's joined. Thank you for your questions. If we didn't get a chance to answer your question, what we will do is respond to those on Twitter throughout today. So please do keep an eye on the Rethinking Medicine Twitter account, which is at rethinking_med, @rethinking_med. So we will respond to those questions. Apologies for those who haven't been able to get to so far. That website again, rethinkingmedicine.co.uk, for all thoughts on rethinking. I've had a couple of questions just about that BMJ editorial. We are trying to get it out of the paywall into a publicly accessible place, and we'll keep you posted about that. I think that's all for today. We've been recording today, so it will be available to watch back, to share with all of your colleagues, friends, relatives. Hope you do that. And with that ceremonial cough, I think we will close today's webinar. Thank you all once again. Thank you, panel. We hope to see you again on a future webinar. Thanks. Goodbye.